Okay, great. I think we'll go ahead and get started. This is Terry Kearns, the Response Subcommittee Chair, and it's our June 4th meeting. I will hand it off to Crystal if you would like to call roll call.
Shayla Holmes. Dr. Terry Kearns.
Present.
Nancy Lindler.
Present.
Christine Payson.
It's either *6 or *9 to unmute on a phone.
I see your hand. I believe that's Christine. I can't seem to unmute you. I can only ask you to unmute. Oh, that looks good.
Hi, this is Christine. Sorry to interrupt. Am I making it through now?
Yes, there is an echo, so I'm going to see if I can combine you. I don't know, Maddie, if that's something
I have it on my my regular computer that doesn't have a camera or a mic because my laptop didn't cooperate. So I'm both on a regular computer, but my voice has to be on the phone.
Okay, and it sounds good now.
And then how do I remute? If it's *6 to unmute, how do I remute so you don't get any other background?
Should just be your phone's control.
Oh, okay, gotcha.
Yeah. Okay. With that, Chair, we do have a quorum with 3 out of 4 members present.
Great, thank you. If you see Shayla Holmes come into the meeting, please let us know. At this point, we'll move to item number 2, which is public comment. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is the period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you're dialing in from a telephone, dial 669-444-9171. When prompted, enter the meeting ID, which is 868-3331-1069, and then press *9 so the host can prompt you to unmute. Do we have any public comment?
This is Crystal. I don't see anyone. Oh, sorry.
That's okay. I was just going to say, we'll just give it a few seconds in case somebody's trying to get themselves unmuted. Hearing and seeing no public comment, we'll move on to agenda item number 3.
And Chair Kearns, I would note for the record that Shayla Holmes has now joined the meeting. She's currently connecting to audio.
Great, thank you. So item number 3 is review and approve the minutes from the May 7th, 2024 Response Subcommittee meeting. No problem, Shayla. Thank you for joining us. If any of the members, do you have any changes or amendments you'd like to make? If not, I have some. Hearing none from my subcommittee members. The first one is a typo on page 3. And it has to do with recommendation number 11. And on that, on the part, the actual recommendation where it's italicized, for example, other persons with a personal and or emotional. I think we have one too many personal in there. So remove the one personal. Great. And then the next is on page 4. And this is a clarification for the recommendation about the 1115 waiver. If you go down where I made the comment about recommendation is currently being worked by DHHS, DHCFP, it should be that rather than updating NRS, it's making amendments with CMS, the Center for Medicare and Medicaid Services, not NRS. So that's just a clarification. And then the last one is on page 6. And it was about law enforcement carrying intranasal naloxone. There it is. Easier for law enforcement to provide intranasal naloxone rather than intermuscular. Then what I wanted to say is law enforcement, to my knowledge, only carries intranasal. That is 4 milligrams. So it would be difficult for them to titrate to a lower dose with the nasal. And as I mentioned, those are just really more clarifications. Thank you for that. With those changes, are there any others that the committee would like to make? Hearing none, do we have a motion to approve the minutes as amended?
This is Shayla. I'll make a motion to approve the meeting minutes from May 7th as amended.
Any seconds?
Christine Payson, I'll second.
Thank you. We have Shayla Holmes with the motion and Christine Payson with the second. All members in favor, say aye.
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 Any opposed? Any abstentions? Hearing none, the meeting minutes will be accepted as amended. And we will move on to item number 4, which we have a presentation on building consensus, defining recidivism in the state law. As the members will remember, we talked about possibly having a recommendation of a BDR for a state definition of recidivism. So we've asked Dr. Katie Snyder and Sherilyn Raw-Wood to come and talk to us about why this would be important. I will tender the mic to Dr. Snyder and Sherilyn.
Thank you, Terry. So Sherilyn and I have talked a little bit about this and the importance of having a consensus. I'm going to introduce myself first so that you know where I'm coming from. I'll turn it over to Sherilyn, and then we'll run through our presentation, which is fairly brief today. Can we get the next slide, please? So I have been working with Nevada's deflection and diversion programs for about 5 years. I started working with first the Reno Community Court on an evaluation for them, and then I started working with the FAST and MOST programs, and I still work with those programs today. I've authored several evaluations for these programs, and defining recidivism has always been a challenge for this, and so that's what brings me to the table today. Currently, I work to consult on data collection and data management for Northern Nevada's deflection and diversion programs under the COSUP grant. I develop quarterly reports, facilitate grant reporting, clean and prepare data for the evaluators, attend monthly meetings, and all sorts of good things. So I'll turn it over to Sherilyn to introduce herself.
Good morning, Chair and Subcommittee. Sherilyn Raw-Wood, most of you know me. I'm the Northern Regional Behavioral Health Coordinator serving the counties of Carson City, Churchill, Douglas, Lyon, and Story counties, as well as supporting the Northern Regional Behavioral Health Policy Board as they work on regional priorities, build their BDR for each legislative session. There's many of hats that I wear to drive and coordinate bringing people together in the capacity to move projects and find gaps and barriers and challenges. The last 2 years really have been overseeing the FAST, CIT, and most Northern Regional Coordinator meetings. These meetings have really been a collaboration of 6 counties, law enforcement, federal and state organizations, as well as communities coming together to really build evidence-based high-fidelity programs for the clients that they serve. I think the most amazing piece of this is that for the past 5 to 7 years, these teams have been coming together as they started building from the ground up. And here we are years later at collaborating stronger than ever. And as these programs make their way across more of the rural and frontier Nevada, really looking at collecting accurate data is more important than ever. And so having a definition of such as a term as of recidivism is really important in deflection and diversion programs. Next slide, please. So why are we here? As I stated, the goal of most deflection and diversion program is really to reduce something. With Nevada's programs such as our MOST, Mobile Outreach Safety Teams, our FAST teams, Forensic Assessment Service Triage teams, our MCRT teams, Mobile Crisis Response teams, specialty courts, and other reentry programs, having a measurable way to define if a program is reducing or not is really important. So basically a way to measure proven outcomes is really what we're trying to define here. We currently collect a lot of data for these programs successfully, but one data point that we've had a hard time collecting for is that recidivism piece, because every county kind of looks at it different. If you're looking at the JPO, if you're looking at adult jail and prisons, that the definition for recidivism is kind of lacking. So it's really hard to kind of find out, is a program working? Scientifically, outcome measures must be defined to help with consistency in data collection to prove and provide accurate evidence that the system or program is working or not, right? One necessary measure outcome needed to be tracked for those diversion and deflection programs is recidivism. But because there's no standard definition here in Nevada, the collection, as I stated, is really flawed and inconsistent. So the art of telling accurate, qualitative and quantitative stories is really being able to explain the story of the points gathered. So we're here to talk about, let's make a definition of Nevada for our state. Next slide.
Right, so going into kind of what is recidivism. On its face, recidivism is repeating or returning to criminal behavior after you've been caught. So somebody might engage in criminal behavior one time, they might have a pattern for several years before they're caught. And then recidivism is when they've stopped for a while, and that could be because they're incarcerated, because their circumstances changed and are no longer inviting criminal behavior, whatever the reason, and then they return to that. And that's a great definition when you're just speaking out loud, but when you're actually trying to measure data points and operationalize that, it gets a lot more complicated. And so we'll go into that a little bit in the next couple of slides. May I have the next slide, please? So one of we have several reasons why we think a statutory definition is needed. As Sherilyn mentioned, departments, agencies, programs all operationalize this very differently. And that makes it difficult to compare. So even across similar levels, one of the tools that we use in deflection and diversion is the sequential intercept model. So that maps out the intercepts on the path through the criminal justice system, starting with first contact, arrest, incarceration in jails, going to court, all the way through. Even programs that operate at the same intercept, for example, specialty courts, could define that very differently. So just as a for example, let's say you have a drug court program and you have a veterans court program, and they're both trying to evaluate themselves, see if they work, try and make improvements. But on the one hand, maybe the drug court program is counting things like failures to appear, speeding tickets, other misdemeanor citations, and the veterans court is only counting anything at or more severe than the level of offense that brought the defendant into that court in the first place. How do you tell which program is more effective, or if they're equally effective with their populations of interest? It's really hard to compare if you're using different definitions. So a statutory definition would really help us guide the policy around how, and the research and the evaluation around how we measure the success of our programs and the standard to which we can expect our programs to operate and that we can hold them to. Next slide, please. We wouldn't be the first ones to implement a statutory definition. There are several other states that already do have one. And then there are several national organizations and programs that have definitions as well. So I went through those to look at what are the key elements, and there's 4 really main core elements to a good recidivism definition. One is the precursor, looking at what the first thing is that brought someone into contact that you're measuring against. That can be arrest, it can be program enrollment, it can be court supervision, probation, any of those things. Recidivism events, so a definition should define what counts as recidivism versus what does not. And this can, in definitions that already exist, this can include misdemeanors, criminal accusations, failures to appear, status offenses. So for example, if something is only a crime because of your status, either as a registered sex offender, someone convicted of fraud or embezzlement, there are certain things that you're not allowed to do anymore that other people are perfectly free to do, like go into school zones or work in financial sectors. So do those count as recidivism? The location and system is an important component as well. I believe one of the definitions we looked at defined recidivism as one of these recidivism events that occurs within the same jurisdiction. So for them, it was the state. One of the benefits to that is that, of course, you're going to have the data. You'll know if somebody's committed a new crime in your state. But the downside is, of course, if your program didn't actually work and it just encouraged them to move across a border, then you don't really know. And then recidivism timeline. The most common timeline is 3 years. That's what NDOC currently uses, and it's what's implemented in a lot of different definitions. But there's kind of 2 elements to that. There's how long of a period of time do you measure recidivism? So you go back 3 years and say, okay, so we're out 3 years from the last time they were incarcerated. Have they recidivated? No, we call this a win. But there's also a couple of definitions that specify the period of time for incarceration or supervision that is required to count as recidivism. So those are a little bit more stringent. I think Vermont is one of them that defines it as any sentence that has you incarcerated for 90 days or more. So if you're just in jail for a couple weeks, they don't count that as a recidivism by their state definition. One of the big challenges to pulling together this statewide definition is making sure that it works for stakeholders across all these different levels. And so that's something that we will need to figure out. I can make some recommendations on that, but I think we definitely want to get some input from the committee here as well as other stakeholders. Next slide, please. All right, I'll turn it over to Sherilyn. She's going to go over some examples and next steps.
So these are just some examples that came from that from the National Governors Association Center for best practices. So you can see Vermont under 28 standard of measure recidivism, kind of how they put it down on paper. And Katie spoke to that violation as at least 90 days. So they have to be in prison for 90 days for that to count as a recidivism. I do know, as I've been talking to JPO, the definition for recidivism for that's going to look a little bit different just because of ages and things like that. So wanted to bring that to the table as well. The National Institute of Justice, the NIJ, according to the NIJ, recidivism is defined as a person's relapse into criminal behavior, often after the person receives sanctions or undergoes intervention for a previous crime. NIJ uses recidivism data to inform parole and probation initiatives to grow the population of justice and involved individuals who deceit. So really important that we have that definition so that we can look at what does that look like when we are informing our parole and probation. And then there's a link on our slide where you can actually go to that National Governors Association Center for Best Practices memorandum. And that really kind of defines all of the state's definitions for recidivism. Next slide. So our next steps, understanding how recidivism is defined will inevitably lead to accurate data, giving us confidence in what Nevada counties share with the state and federal government. Identifying real time where more recidivism is occurring according to accurate data would be essential in allocating resources and funding, and then reallocating those harder affected areas. We know Nevada collects a lot of data. We do collect a lot of data, but a lot of times we just don't know how to use that useful data. Maybe where we use it, how do we tell that story? So understanding a definition really helps us to create those stories. When we're looking at that public safety transparency, being able to share accurate data with the public is even more important. As you know, in recent years, there seems to be a lack of putting out quality data as well as receiving it. Data and storytelling is a huge piece of transparency, which we know is a real struggle with a lot of our programs, operatives, information coming down from state and federal. When the public knows what is truly happening in their own state and communities, there's a shared sense of stability and safety, reducing anxiety and other triggers caused by feeling unsafe and uncertain about what is happening in our nation, state, and our own neck of the woods. So really understanding what that looks like is important. So what are our next steps? Our really development process, outlining the steps involved in developing a bill draft to change the language or add language to statute, looking at that research, stakeholder consultation, drafting, revision of that. Really having that support from this subcommittee would be awesome as we work towards creating that definition for statute. Stakeholder engagement is really, really important. So potentially maybe creating an advisory committee to really stress the importance of engaging various stakeholders such as law enforcement, policymakers, advocacy groups, the community, those with lived experience, all the above. So our call to action is really to encourage you guys to support this initiative and participate in the drafting process and really understand what that looks like when we're talking about recidivism here in Nevada. So I would invite questions and maybe perhaps further conversation, discussion to really define what that proposed definition looks like. But in closing, I want to remind the subcommittee, Nevada has always struggled with data collection and accurate collection of data as well. Although we collected a lot of it, a lot of us don't know where to go, how to find it, all that stuff. So it has been getting better, especially with adding research and evaluation partners to the table when working on program development. I think that's really important. It's an important piece of this too. Without that research and development at the table, helping us develop these programs and writing handbooks and really dialing down that data, we wouldn't have probably a lot of the questions that we're bringing up to the table right now. It's been really important as we're developing these to bring that evaluation and a research piece to the table. And that really helps us identify the gaps and barriers that are transpiring within each county or the state as a whole. And with that, we will open the floor for questions and concerns.
Committee members, any questions for Dr. Snyder or Sherilyn?
Yes.
Please go ahead.
Is there, Shayla Holmes for the record, is there a recommendation that you guys are making? I mean, yes, we need a definition for recidivism. I think we agree on that. I have concerns, right, with what was proposed, like Vermont's language. I think 90-day sentence is not going to work in regards to a local incarceration. If that might work as far as like a state correctional facility, but that's not going to work for county facilities and how we prove concept for our local deflection programs, right? So I guess I'm just curious, like, do you guys have a recommendation of what you would like to see the measurement of recidivism be?
Yes. So I don't know exactly how this would need to be worded to be a successful bill draft, but I think that it would make sense to define it as at or above the entry level for that program. So for example, to be enrolled in FAST, if FAST is the one measuring recidivism, you have to at least be incarcerated in jail. And so anything that has you incarcerated in jail, whether that's temporarily with pending charges or longer term sentenced up to a year, would then count under that, versus with NDOC, it would require a return to prison, which is what they currently use as their operating definition. And so I think if we can look at it at that point, we would be getting different measurements at different intercepts, but consistent measurements across the same intercept of justice system involvement. So rearrests for law enforcement violations and rearrests for parole and probation. Does that make sense?
Sort of, but are you saying like for perpetuity, like forever? So recidivism, I get arrested today, and I go to my county jail. So here I am, day one, my first offense, but I get out, I'm connected to FAST, so I'm super successful, and I go 2 more years without being arrested again. But is that still being considered as a part of the definition of measurement of recidivism? Or because I'm just trying to figure out how we would show outcomes with just an indefinite period of time.
Yeah, so I don't think we should look at an indefinite period of time. The most common time frame used is 3 years. So among the existing definitions, most look back 3 years. And just to kind of back up a little bit, one of the other benefits of having this structure is data sharing. So as Sherilyn mentioned a couple times, we're great at collecting data, but a lot of the data, especially justice system data, is very siloed. And so the hope is that a statutory definition would also provide parameters to guide data requests for sharing. So if I, as an evaluator for FAST and MOST, need to get data from the justice system, from whether that's through the Office of Analytics or through the CJIS system, I would have parameters outlined in the definition that can already guide what I'm asking for. As you may or may not know, justice system and health systems are very protective of their data, and they don't want to share any more than they have to. And so having this would also help guide what those requests look like and build data sharing. But yeah, to answer your question, I think 3 years would be an appropriate amount of time. And then within that, programs can always look at what's the average time to recidivism within 3 years. You know, if on average people who recidivate within 3 years are going 6 months versus a year and a half, that still speaks to some of the efficacy of the program.
Thank you.
Kind of to that point, Dr. Snyder, you made the point of if it's lesser interaction or a rearrest or lesser charges, that still does tell you something about the program. But I wonder, in having a BDR developed, one of the things that I believe it was Shayla brought up at our last meeting was looking at arrest in different counties. So, you know, and how that would be addressed across, because as we know, often our people that are in these programs do go from county to county. So any thoughts on that?
I think that's one of the reasons why if we put together an advisory team or something, is bringing those people from different counties to really talk about what they're seeing. Because we really can't develop something if we don't have everybody at the table, but we really have to have those voices from every county to talk about what are they seeing? What does that look like when it comes to rearrest? As Katie was saying, that data sometimes is hard to get, but we know sometimes from county to county, we're having those frequent voices show up. So understanding how that would look, bringing those people to the table to devise what that data sharing would look like when we're looking at that piece, I think is really important. But that collaboration and having those voices at the table, I think is where we start as we're trying to develop this definition to create a BDR. Does that help answer that question, Dr. Kearns?
It does, thank you.
And I'll just add on, as far as I know, I mentioned in the key elements that geography can play a factor. I would encourage whatever definition we propose to encompass at least the state of Nevada. If we do decide to restrict it geographically for the purposes of accessing the data, or because if they leave state lines, then we don't necessarily worry about them anymore. Whatever the case may be, you know, I would definitely want it to encourage sharing of information across county lines, because we do already know that that's a huge deal. We see a lot of people moving between counties, even after they've been arrested. I think Douglas is the overflow jail for Carson City, and so they may move not even of their own free will.
A good point. Christine, can I ask, is this something that you have addressed at all with the sheriffs and chiefs?
No, that had not come up. They like to put it out to them as they do other group email.
Yeah, they would be a big stakeholder in all of this, I would well think. Any other questions from the committee members?
This is Nancy Lindler. For the record, I do have sort of a question and a comment. Is it valuable, and if it's in there and I missed it, I apologize, but to distinguish between someone who's incarcerated in jail, like the different levels of incarceration involvement, if that's the right way to say that. And the only reason I'm saying that is here at Rich House, we're a prison reentry program. And I have 3 guys that together have 100 years of incarceration in prison. They are the definition of real recidivism, I think, in a lot of ways. I'm just curious if it's valuable to have a distinction between the different levels of incarceration, if that's something that might be valuable.
I would think so. And we would definitely want your input on that. For example, if somebody's sentenced to 300 days in jail, I think under the current operating definition for NDOC, that would not count as a recidivism. They would have to come back into the prison system to count as a recidivism. And so proposing that what counts as recidivism has to meet the level for reentry into that level of the justice system, or that intercept of the sequential intercept model, would already separate prison and jail into 2 different categories.
Okay, thank you.
Any other questions from committee members? Sherilyn, I know that you're not here for this, but I'm going to take advantage of the opportunity of you being here. And I know that you said you've been approached by DHHS about getting some input on the 1115 waiver, which is getting Medicaid benefits from someone leaving a carceral facility up to 90 days before they leave. And that was a recommendation that we had in our 2023 SURG annual report. So if you can provide us any just update on what you're being tasked with.
Absolutely. Thank you. So I think one of the greatest things that came out of these meetings, monthly meetings with so many counties being involved in, was the recognition from the state that we are cross-collaborating, that we're coming over county lines and working together, building great programs. And so we finished a almost 200-page handbook for the FAST program. And it's been vetted by the state. Now we're waiting for the AG's office to kind of finish it up as we move forward. But through that development, we were asked by the state to turn our FAST monthly meetings into creating, once they get the 1115 waiver really solidified in CMS with Medicaid, to create the technical bulletin for that, and really look at how do we work with our sheriff's departments, with our providers that are going to be implementing the 1115 waiver. What does that look like? How do we process the paperwork, like the nuts and bolts of what that's going to look like? So really excited about that. We know we're probably about 6-7 months until we actually get the go ahead to start writing that technical bulletin. We can't call it a handbook because it's not going to be that many pages, but it'll still be pretty hefty, and that'll be a statewide brochure, whatever you want to call it, to really help us move the 1115 waiver forward. I think the state is starting to look at how do we really create things to train and bring programs to fruition. So excited about that. I'll keep you guys posted on how that's developing as we get the go ahead from Medicaid and the state to do that.
Great, thank you for that update. I appreciate it, being that was one of our recommendations. Thank you both. You are welcome to stay, or if you need to go, we understand. But thank you for a great presentation, and it's much appreciated.
Thank you for your time.
Thank you.
We will move on to item number 5 on our agenda, which is a presentation from the Center for the Application of Substance Abuse Technologies, CASAT. And I don't know if it's Michelle Berry or Morgan Green, but whichever.
Hi. I'm like Morgan Green. Unfortunately, Michelle got pulled into an advisory committee for the university, so I'm here. But thank you guys. We just wanted to provide a quick update on some of the activities that are happening with the Opioid Technical Assistance Center, which has been branded the Opioid Center of Excellence. And so we have several activities that are moving forward. Now, we want to point out there's different branches to this center. We do have widely public trainings that are available. We have ongoing on-demand videos that are always going to be available, but we also provide very specific technical assistance or trainings for specific organizations in the communities or communities themselves. And sometimes those help us to identify trainings that need to be towards the wider audience. So we want to ensure that we're meeting the specific needs of the communities that are requesting us, but also recognizing that there's some things that are going to cross over that are statewide. So through this, if any of you guys have seen the website, it is just the nvopioidresponse.org website that we've been using for SOAR. We've revamped it, so this is just an extension onto that. This also still includes all of those other links to other opioid programs within the state, such as OD2A, as well as SOAR, so you can still see the activities that are happening amongst those state projects. Through this, we also have opioid regional coordinators. We just brought the first one on this week. And those are going to be individuals who are directly out in the communities, talking with stakeholders, talking with community members to help identify barriers that exist in the communities, as well as what some of their specific needs are, and help link a lot of that. So really coming in alongside the regional behavioral health coordinators and taking some of that burden off of their plate. And then we are also working on developing the behavioral health echo. We finally got approval, so we should have that going by this fall. So we will have clinics that are ongoing, that'll provide opportunities for long-term series to help provide a little bit more in-depth information as people develop and build programs. We do have the self-paced training that we discussed, and then we have listening sessions, which the first one was just announced, and I see there's been a lot of people who have already registered for that, so we're excited. This first one is going to be specifically on diversion and deflection programs that are happening in the state to help identify some of the things that are possible to do, and hopefully start some of those discussions in areas that have been thinking about it. Next slide, please. Perfect. So this is the revamped website. As you can see on here, there's still direct links to identifying locations for naloxone, if anybody is looking for that, also as well as test strips, how to find treatment behavioral health programs that have been SAPTA certified, and then how to request trainings. So we want to make sure that people have a quick access to all of that information as they need. And we kind of covered some of the activities that are still going on there. Okay, next one. Perfect. And these are the upcoming live events. So these are the activities that are happening. Registration's currently opening. So the first one is that first listening session, the prevention and diversion programs. We have multiple individuals who are heavily involved in some of these programs who are going to be talking about their activities and what it took to get them up. With that, we're also launching a podcast to keep those conversations going. The second one is the Good Samaritan and drug-induced homicide laws that we're working with some individuals at the AG's office to help provide to see if we can get some more information as to how those two things really intersect and where those gray areas lie, just so that we have broader information. There's still a lot of fear out there around individuals calling 911 for assistance because they just don't understand where those lines lie. And then the third one is the community response and best practices for opioid antagonists. So we really know that there has been several very aggressive campaigns by different pharmaceutical organizations within the state promoting medications that we don't necessarily have the research to support. So we want to ensure that individuals have the current research and are making informed decisions as they make their requests for different medications. There's a medication for every time and place, but we want to ensure people are using the right ones at the right time to reduce any sort of concern or damage to the relationships that we've made with individuals who are high risk. Basically, we don't want to drive this underground, which is going to result in more people dying. Okay. And then next. And then we do have some on-demand videos. So these are self-paced. People can take them as they come. The existing ones is we've updated the overdose education naloxone distribution for law enforcement. It now includes xylazine, as we are seeing that coming in increasing numbers. And we do expect it to hit pretty significantly hard in this next year if we're following traditional trends, as well as overdose education for communities. We have an upcoming Spanish-focused overdose education, as well as basically MOUD 101. There's increased interest, especially in the rural areas, for how to develop MOUD programs. We want to just kind of start that discussion and get some of those basics in there, and then hopefully we can expand some of that technical assistance to ensure that we are getting those agencies up and running. Overdose education for pharmacists, and then AB 156 review. And this is, again, pharmacist focused, but with AB 156, there has been a move to allow pharmacists to provide medication for individuals with opioid use disorder, such as Suboxone. There's a lot of questions around that. We want to see if we can help provide some of those answers. So just as a note, with those trainings, there is a compassionate overdose response that is built into those overdose education pieces. That's really a huge focus. We want to ensure that people are doing this, again, to discourage people from going underground and keep individuals in a position where people are going to be able to intervene on their behalf. And as for naloxone in the hands of law enforcement, so we do have several law enforcement agencies that are participating in leave behind programs. After talking with them in particular, sorry, this is independent. I just know this is a secondary question. Talking to a lot of law enforcement agencies, one of the things they've pointed out is that, especially when it comes to overdoses, they tend to be second responders. The first responders tend to be the fire departments. So we are trying to expand the leave behind programs with fire departments and EMS. Up in Washoe County, REMSA is one of our biggest leave behind programs, as well as the Sheriff's Department. Las Vegas, Henderson has their EMS program doing leave behind programs as well. So that is something that's still being developed, and nobody's really against it. There's just not a lot of, I guess, identification of need on the ground. So as for the mobile units, so all three of the units have been purchased and are here. They are wrapped with the UNR logos just to help reduce any stigmas that individuals have as they are going to be placed into the hands of treatment agencies. 3 agencies have been identified already. We're currently working on their budgets and scopes of work to get these rolled out. They also all have satellite Starlink attached to them so that we can ensure that as they're out in the rural communities, they can still provide those services. So as you can see, they're fairly large on the inside. There's room for 2 exam rooms, as well as a restroom, a lot of seat belts. Next slide. So the services these are the minimum services that every unit is required to provide. They can always go above and beyond, but this is what they are specifically required to provide. So the administering of medications for opioid use disorder treatment, they are not going to be carrying the medications on board. Instead, they're going to be working with pharmacists in their communities that they are stopping at. So part of this job is to develop those relationships with those pharmacies to ensure that we can provide that their medication will be available as this is going forward. Collecting samples for drug testing or analysis, they're going to have the ability to do that on board. Conducting intake and psychosocial appropriate medical assessments. So they're going to have the ability to do full physical examinations, those initial substance use screenings, as well as assessments to help really kind of elevate or get people involved in the treatment system a little bit faster. And then administering FDA approved MOUD. So once the medication has been acquired, they can help do that induction on board. And then counseling and other services such as peer recovery, community health worker services, or case management can be provided on that site as well. And they're all going to be able to provide the telehealth services. So kind of providing that link. Okay. So that's what I got for you. Does anybody have any questions?
Committee members, any questions for Morgan? Morgan, I just had a couple of quick questions.
Great.
I may have missed this, you may have said it. Did you say that these are going to be in all of the rural counties or starting in the northern rural counties?
Great question. So it's not going to cover all just yet. This is still the pilot program. So there's the agencies identified. There's going to be one that's going to be in the northeast part of the state. One is going to be covering the Quad counties, and then one is going to be in southern Nevada, so covering the rural components of Clark County as well as Nye, and the surrounding counties. So we want to kind of cover all of those bases. I have questions as to how well the UNR logo is going to go over there, but we're going to find out.
I love it. Thanks. Hey, and my other question is this still being determined? Like the routes where they're gonna go, is that part of the assessment and the going out to the communities to see what the needs are?
Yeah, that's going to be part of that assessment piece, because a lot of that is also going to be built on just having those pharmacies and everything that they can access those resources. And as we identify those places that don't have that at all, then we're going to be troubleshooting. So I think a lot of those routes are going to be really kind of based on those initial established relationships.
Is there a date when they'll be up and running yet? Or to be determined?
It's to be determined. So we're working on getting the budgets and scopes of work in place. Once we have those in place, then they can be up and running once they're staffed. So I think that it really depends on how long the staffing process is going to take.
Yeah, that's great. Thank you so much for the update. I'm anxiously awaiting all of the programs that you talked about. Good stuff you guys are doing.
Great.
Great. And you're welcome to stay, or if you need to leave, we understand. We're going to move on to our next agenda item number 6. Thanks, Morgan. So agenda item number 6 is an overview of new recommendations received and the next steps. The first one, which I had submitted and you heard about today, was to recommend a BDR for defining recidivism in NRS. As was laid out today, I think we still have some questions and some stakeholders we need to get on board with this. So there's still going to be some work to be done as to what that definition will be. Will it be within a 3-year? What types of offenses are we talking about? And then also, how are we going to address that across county lines? So I think there's still more to be done on this. The next recommendation, so I think we're going to have to convene and get some additional information on recommendation number 1. Recommendation number 2, Shayla, this was your recommendation. If you don't mind, I'll let you address this one.
This recommendation I made in response to our last meeting, where we had Bill Teal and we were discussing the need for data sharing. The state of Virginia has a pretty innovative database where there's a variety of different data points collected across multiple professions. So the local social services, public safety, corrections, drug courts, community coalitions, they all have mandated data sets that go into one data system. And so it's able to provide really in-depth information in regards to substance misuse or substance use within localities and then as a state. And it also has some predictive factors, which is pretty cool, which allows localities in the state, whichever level of government you're looking at, to be able to access their de-identified data and see what intervention methods are being used and what outcomes are being seen. So they're doing really cool, innovative stuff through this framework for addiction analysis and community transformation. And the way that they were able to do that, so It clearly they didn't do it overnight. But it took MOUs with the state data department. So their chief data officer holds all these MOUs with all of these individual agencies. So all of this information is able to be funneled to one point. And I thought, what a great way to start it, to be able to start breaking down the silos of some of this data and be able to start really collecting some of it. And then it did take some legislation to mandate the participation of specific entities. So specific entities within the state of Virginia eventually did end up being mandated to participate in this system. But it all started with the data sharing agreements through their state. So I thought that would be a great place for us to start looking and seeing what do we already have in place that could allow this to happen, or is there something that needs to be changed to allow this to start happening? Because I think enough people have talked about the need for data sharing. I think we've talked about it enough. Now we've got to figure out how we start implementing, and Virginia did an excellent job. So I figured what a great place to start trying to model ourselves after.
I agree. And I think that was one of, out of the legislation was the mandate of looking at data sharing as well. So it sounds like a next step for this is to get a presentation from either Ken or Jason or both.
Yeah, I don't have any working relationship with anyone in Virginia, so I am not sure if this Mr. Ken Feel is hospitable to wanting to participate and engage with us, but I think that would be a great source if he was. I imagine, I also don't know Mr. Jason Benshoff, but he's local-ish, right? He's in the state somewhere. So I imagine he would absolutely, I'm totally speaking on the poor guy's behalf, but I think he'd be willing.
Sounds good. Any other comments from other committee members or questions on either recommendation 1 or 2? The one comment I would have is, again, Christine, I think both of these would be good to present to the sheriffs and chiefs to get their feedback on these 2 recommendations as well.
Agreed.
Okay, I know we had talked, we don't have them as official recommendations, but I know at the last meeting, we talked about the wastewater based epidemiology and potentially getting a presenter to come and talk about that is from a state maybe that's already using this in the capacity we were looking at. So that's another recommendation. And any other recommendations?
Just I guess a point of clarification for the wastewater epidemiology conversation. Do I need to resubmit that as a new recommendation for this go around? Or with our recommendation the last time being to continue to research? Are we just acting upon our previous recommendation, or to keep it current? Should I resubmit that? I'm just not sure how we want to go about that in this process.
Yeah, Crystal, correct me if I'm wrong, but I think if we want to readdress a prior recommendation, we're requesting them to be resubmitted. So, so it would need to be resubmitted as a possible one for this year if we want to readdress it. But I think that one is definitely worthy now that we know some other states are using it and can find out the process and how they are using it.
Crystal Duarte for the record, I would say that's true resubmitting. If you don't think there's any new information to add or revise to it, I do have the information and can easily pull it over, so you wouldn't have to resubmit that particular one. I just wanted to note that if you do want changes or you think there's new justification or links, that would help to resubmit. But I'm happy to get it started with pulling over what we had from last year.
Yeah, I mean, if you're able to email me what I should probably know what I submitted last year. But if I did it on the survey, I don't have it saved somewhere. So I don't know if you're able to send it to me. That would be great, because I'll go in and edit it, and then I'll see too, because I know we've seen some recent articles on how other states are utilizing it for this purpose. So I'll see if I can't incorporate that into some of the backup information and come up with something additionally to keep it fresh.
Thanks, Shayla, for that. And I think also for the recommendation on an overdose fatality review, we were going to wait and get the report out from the Clark County Opioid Task Force, although that's not an official overdose fatality review. We wanted to review those. So I don't know if we would get that in time to have it as a recommendation for this year or just follow that until next year. Thoughts on that from committee members?
I suppose, I mean, what's our final date to have our recommendations submitted by? Is that's already passed for this first one? No, Crystal's like, heck no, keep them coming. So I mean, I think maybe we hold off until we do have additional information on that. And if we're able to squeeze a recommendation on in at the last minute, with new information, I just think sticking to that previous message of if we have something new to add, let's resubmit it. But if we're still just in a holding pattern, I'm not sure what that.
Yeah, and Sheila, to your timeline, I think it's October when we're going to report these all out to the larger surge. And then, you know, as we did last year, whether they need to come back for being reworked, or if there's a couple of subcommittees that have similar ones, again, getting them remanded back to kind of combine too, if they're similar. So I think October is really our deadline we're looking at for having these so we can present to the larger surge. Is that correct, Crystal?
That's correct.
Okay. And then the other recommendation, which we might get some more information based on Morgan's presentation, is the recommendation about the looking at any conflicts between the Good Samaritan Drug Overdose Act and the drug-induced homicide. Maybe after those listening sessions, we can get more data from Morgan's group on what they're finding and if there is a conflict or if it seems like it's been better laid out. I think that's all the previous ones we were looking at. And I know, Christine, when you were going to reach out to the sheriffs and chiefs to see if they had any recommendations they wanted to bring forward as well.
Yeah, I did have some conversation with someone in Story County, and I don't know that it's necessarily a recommendation or how I would possibly turn it into one, or it might even be overlapping, but the gist of it is they're concerning how the settlement funds could be used in rural counties, specifically the Story County Detention Facility, when housing inmates who are addicted to opiates, and how they could get assistance with funding for the medications for meth. So I know there's been a lot of discussion about incarcerated individuals in special populations, but what his first steps would be to actually access any monies that are already coming in, or do we turn that into a specific recommendation? I'm not sure.
Yeah, that's a good question. And I know that Bill Till has his program that we heard about trying to get MOUD. So maybe we need to reach out to Bill and find out the funding for that. If that's going to be if someone's on Medicaid, it would be paid for. If it's paid for through the jail, if it's paid for, by what mechanism. I know there have been some counties that already, such as Washoe, I know for sure, is pushing out some notice of funding that might not be the exact or applications for the use of their funding. And then I know also that the Fund for Resilient Nevada has pushed out NOFOs. So those may be two ways as well. Any other comments or thoughts on that from the other committee members?
also I just want to make sure that I'm, sending him in the right direction. Would you suggest that I connect him with Bill Teal as well as the Fund for Resilient Nevada as the first step to see about getting that, or do I want to turn it?
Or we can reach out and get you the answer and get that provided to him.
That would be great, thank you.
Yep, no problem. Any other thoughts on recommendations from committee members? Are we good? We've got 2 definitive ones, and then it sounds like possibly a third in the wastewater with some updated information, and then we're going to have to wait and see what we find out on the other 2, being the Good Sam and drug-induced homicide. And what was the other one?
Terry, I thought I'm certain I didn't dream this because it was a new news to me. Something about like compassionate response. Was that something that you had brought up that I thought was very interesting?
I did bring
that's
that.
all I know.
Yeah, I did bring that up. It sounds like for one that they're going to be doing that out of the Center of Excellence. They're going to be doing that. She said it's a component of all theirs. And I think we were going to try to get Dr. Carla Wagner to come speak more about that. Is that correct, Crystal? Or am I making that up?
I hadn't heard that, but you're right. I'm glad we're bringing this up again, so I can do any outreach on that, that we need, and Dr. Wagner is probably a good fit.
You're correct. We did talk about that. So I don't know. We'll have to find out if that's something we need to make a recommendation on, or that it's already being done, it sounds like.
Okay. Yeah, I mean, learning more about it would be great. I don't know if that's necessarily something I just need to go do on my own, or if it's something we're gonna do through this. Only because it's such a 180 from where we were at one of the cross-sector task force meetings in response to overdoses. They were talking about moving towards intravenous injection naloxone for frequent intravenous users, and then talking about the distribution and increasing to the 4 milligram naloxone for the intranasal spray, and that was what was going to be coming out of CASAT soon because of the fentanyl. But after hearing you talk about the compassionate response, it just totally like flipped my mindset and made me consider maybe this is something that I at least need to be aware of. And then I'm not sure what that looks like as far as how we engage with CASAT as practitioners out here in the field and what we're distributing to the community. I don't know if we're going to be able to request 2 milligram versus 4 milligram. I don't know if that's going to be a preference, but all interesting stuff to watch out for. Again, I'm not sure this subcommittee is going to make a recommendation on it, or if it's something we need to own, or if I just need to, but it was certainly enlightening. So I know that much.
Yeah, and Shayla, I think all your points are well taken. In some of the presentations I saw, which I think Dr. Wagner could speak to, is there certain places that very rarely even use naloxone, as opposed to more like rescue breathing, and it's bringing the person back to breathing, not to full consciousness. So, I think there's a lot of components of that. And my understanding, and I think Morgan's still on the line, if we can get her to answer this, it was the state looking at getting higher than 4 milligram dosed opiate antagonist. Is that correct, Morgan?
Hi, Morgan. Yes, so the standard intranasal is actually 4 milligrams. There is a 3 milligram that we would love to get our hands on, but we haven't gotten there yet. But the standard's the 4 milligram. They're pushing for the 8 milligram, which is one of the things that's going to be addressed in one of those trainings. There is zero research to support the benefit of it, and it does not work better on fentanyl. I don't care what campaign they put out there. So that's one of the things that is still in discussions at both the state level and at community levels. So we really want to ensure that people are getting the accurate information based on research that's being done outside of the pharmaceutical companies themselves.
Obviously, I knew it was double, 2 to 4, 4 to 8. I knew. Thank you so much for that. And so maybe, I mean, I guess we need to, after, similar to like the Good Samaritan law, after the listening sessions, being aware of what the center is doing, because I don't know if we need to support them with the recommendation on something along those lines, or if their work is going to be sufficient enough to stand alone. But I suppose that's just something we want to keep on our radar then.
Yeah, that's a good point, and we can follow that up and see. But I would recommend Dr. Wagner speaking to it, because like I said, there's a lot of information that came out of a meeting that she attended. And for example, I know xylazine is not an opiate, but there was some discussion on whether it assists at all at giving naloxone. So, you know, those are the kinds of questions I think we could have addressed by Dr. Wagner too. And we'll invite Morgan back later to see how the listening sessions go.
Love to give you feedback.
Here, Kearns, I just skipped. It sounded like we were kind of talking about future, so I don't know if you wanted to announce this agenda item, but I think we've discussed it a bit. You're muted.
Thank you. Planning for our 2024 response subcommittee meetings. As was highlighted today, we had the presentation from the Opioid Technical Assistance Center, and then for defining recidivism. We have requested, but it would be to the full surge on the Oregon drug decriminalization, and I think that is scheduled for the surge. We also wanted to address workforce, to look at that in August. Wastewater treatment epidemiology in August also. And then that Clark County Opioid Task Force, once they have their report, to get a readout from them on their report. I had an additional suggestion. If we have time, it would be to get an update on the 988 crisis response, kind of where they are, what's been done. And the reason I ask is because we did have our recommendation about the overdose response teams that also included support for family and significant others. And I think that's recommendation number 11 from the 2023 SURG annual report. So that was one of the things I was interested in, is that I think, Shelley, you had brought up that might be a component of the 988 crisis response. So that would be my recommendation, if we can get an update on where they are at with the 988 crisis response. Any other suggestions from the committee members on potential topics or presenters you'd like to see?
I don't know if it would be possible to try to get either or both of those chief data officers to come and present on the data service agreements. I looks like we've got pretty full schedules, but well, I guess whichever meeting they're available that we have time and space for.
Great suggestion. Thank you.
This is Crystal directly for the record. I did note that, and I think we could actually probably fit that in August. And I don't know how the subcommittee would feel about this, but there are 2 workforce presentations planned for the full surge. So in addition to the Oregon experience, we're going to have 2 presentations that relate to workforce. So we could move that workforce specific to our subcommittee to September, or determine what next steps we want after hearing at the full surge in July. So I would just say it looks full, but that one I think might move around.
Yeah, that's a good point. So maybe if the presenters are available for August for the whole data sharing, maybe we could get them in there, and then the subcommittee could decide if we need anyone else after seeing those presentations at the July surge on workforce.
Maddie, for the record, one quick question. Where would you want Dr. Wagner to present for the compassionate overdose response? Maybe in August or September?
I think part of it's going to be her availability too. So,
Why? Okay.
so August or September would work, but I think we need to reach out and see what works for her as well. Any other requests or for presentations? If something comes up, please reach out to myself or Crystal. And we'll move on to the next agenda item, which is to discuss the report out for the July 10th surge meeting at Chair Holmes.
Well, here we are again. We talked about it a little bit in May, that in July, all subcommittees will be reporting out to the full surge on the work thus far. So I think it would be definitely the two recommendations that we have in the presentations we've heard thus far. Is there any other discussion from the group as far as what they would like for us to report out on in July in regards to the work that our subcommittee is doing?
But this is Chair Kearns. I was just going to say, we may just want to add that we are looking at those other three recommendations, but trying to gather more information, and we may, I don't know if recycle or update those as recommendations as well.
Yeah, I made a note of that. I was thinking we should probably mention like the fatality review, that we're sort of in a holding pattern on some of those. So I would absolutely agree that we would want to keep the full surge in the loop as far as what our potential plans are. Any other thoughts in regards to the report out in July?
I don't know if this is a report out or if it's more a question that we're going to have to get answered. I know that we have talked in the full surge about adding membership to the additional members to the membership of the surge. So my question is that a recommendation that's going to have to come out of the surge, or is that going to be a BDR that the AG is going to submit separate? So I think we just need to get an answer to that at our next surge meeting. So we need to know whether that needs to be brought forward as a recommendation or has already been brought forward. It's just not 100% clear to me.
That's an excellent point of clarification for sure. And would we be the best ones to bring that forward, since we're the community response subcommittee and we're looking at increasing the community representation? Perhaps it's a good fit. Yeah.
I think you just justified it.
Yeah. Right. Oh. Well, Terry, we're working on keeping your report out very minimal. So it sounds like just right under a couple minutes.
No, that sounds good. Thank you for that. I think that the July surge meeting is going to be pretty packed already. And I just want to update everyone. We talked about the July surge meeting being at our new location for the Attorney General's office. I don't think that move's going to happen before then. So the surge meeting for those of us down here in Vegas will be all virtual, because we're not quite sure what's going to be available to us in terms of meeting spaces. So just an update to you all.
We jinxed it.
We did jinx it, didn't we? Hearing nothing else, it sounds like we're ready to go on to the next agenda item, which
Yes.
is item number 9, public comment. Again, if anyone has public comment, either raise your hand, unmute, or you can call in from a phone at 669-444-9171. When prompted, enter the meeting ID at 868-3331-1069 and press *9 to unmute yourself. Is there any public comment at this time?
Chair, I'm not sure if this would be public comment or not. But I suppose to just get it on the official record within the chat, Joan Waldock shared that the NOFO, the Notice of Funding Opportunity, was released through the Account for Resilient Nevada, and supposed to get that out to the public officially via our minutes, since that was something shared via the chat.
Thank you for highlighting that. We'll give it just a few more seconds to see if anyone needs just time to come off of mute. Seeing or hearing no one coming on for public comment, we'll move to agenda item number 10, which is an adjournment of the meeting. Thank you all for your time. Our presenters, thank you. Excellent information today. And I guess the next time I'll see everyone will be at the July 10th SURG meeting. Thank you.
Thanks, Terry.
Bye.
Thanks, Crystal.